any focal neurological deficit. She didn't have any physical signs or symptoms pointing towards any systemic connective tissue disorder or vasculitis, without any history of any preceding infection. She has been mentioning about some poor oral intake. Blood pressure control had worsened over last 6 months with some on and off pedal edema and shortness of breath. She was admitted to ICU. GTCS was managed. It was found that she had a creatinine of 11. Dialysis was initiated. These were her labs. Significant anemia, mild thrombocytopenia, severe renal dysfunction, calcium of 8.2, albumin 3.3, magnesium normal, urine analysis 1+ albumin, RBC is 30, pus cells 14, a 24-hour urine protein of 1050 milligram, viral screen negative, ANA anti-dsDNA negative, a low C3 with normal C4, ANCA negative, ultrasound showing normal size kidneys with grade 2 renal parenchymal changes. CT brain was normal and echo showed apical IVS hypokinetic with EF 62%. She was, so here the clinical differentials where she had clearly come with hypertension and seizures with a creat of 11, so uremic with or without a hypertensive encephalopathy, subnephrotic proteinuria with a renal dysfunction. It could be a RPRF versus an AKI on CKD with such a significant anemia. So the possible differentials that we had kept were a post-infectious GN considering a low C3 with a normal C4 or an atypical HUS with such a significant anemia, some mild thrombocytopenia there with a low C3 and MPGN. There could also be some double pathologies, so other things also need to be ruled out. And so she was dialyzed with 5-unit PRBCs transfused. She developed an acute coronary syndrome, non-estelation MI, which was medically managed with antiplatelets and heparin. After 2 weeks, she developed a catheter-related bloodstream infection. And all these events, one after the other, led to a delay in her renal biopsy. The delay was by almost 4 weeks. And then a kidney biopsy was done. Over to Dr. Radhika for discussing the biopsy histopathology.
Thank you, sir. I welcome ma'am over here. Dr. Radhika Krishna Patil, ma'am, she is a director and consultant nephropathologist at the Sri Balaji Diagnostics, Hyderabad. She's current vice president of the Basic Sciences of Indian Society of Organ Transplantation and an ex-consultant at Yashoda Hospital and Star Hospitals, Hyderabad. Over to you, ma'am.
Yeah. Good evening, dear all, and the respected faculty. Happy to be part of this Nephrocon meet. So we received the biopsy, and this is a PA stain, periodic acid skip stain. This is renal capsule, and this is the subcapsular cortex. These 3 ball-like structures are the glomeruli, and this is tubulointerstitium. So this is a 4x scanner view. Here we can appreciate again few more ball-like structures, glomeruli, and the tubulointerstitium is showing some loss of brush border. There are some PS positive hyaline casts giving the evidence of tubular injury. Here we can see that this is PS positive glomerulus, and there is something PS negative extra capillary proliferation, that is the crescent going on. Again, the biopsy core, this is showing us completely globally sclerosed glomerulus and some mild IFTA tubular atrophy and interstitial fibrosis. Again here, we can see there is an arteriole, and beside that at 4 o'clock position, this is a remnant of a crescent. Only extracapillary parietal epithelial cells we can see here. So there is an ischemic glomerulus also. And here are some red cell casts in the tubules. And few tubules were showing this luminal calcification, giving again the evidence of tubular injury. So coming to H&E stain, and this is 20x lens, and it is showing a glomerulus. This is hypercellular, and it is showing enlargement of the size. How do we decide the size of a glomerulus under the microscope? That it is 2.5 times size of the proximal convoluted tubule. So if it is more than that, then it is called as hypercellular, or if it is not fitting under the 40x lens, high power, then we can call it hypercellular. So this is that is enlargement. Normal size is 2.5 times of the proximal convoluted tubule, and this is more than that, and also not fitting under the 40x high power. And here we can see there this capillary lumina, they are obliterated. There are some cells, so there is definitely endocapillary hypercellularity, mesangial hypercellularity, and there is extracapillary hypercellularity also. Mesangial hypercellularity we can see in PAS stain, that is a special stain, and in between two capillary lumina there is mesangium. And in Heptin style, under the Banff criteria, all those 13 to 14 categories, there is last line is given that MM1 is that more than 2 cells in the mesangium is mesangial widening, that is up to 3 cells, and more than 3 cells in the mesangium is mesangial hypercellularity. So here there was nothing like that. It is just endocapillary hypercellularity obliterating the capillary lumina. And this is a silver stain which is showing cellular crescent and the remnant of the tuft. The tuft is hardly visible, but still we can appreciate there is basement membrane thickening and duplication along with the mesangial cell interposition. So it was MPGN kind of pattern, though there was not so evident of this lobular accentuation of the tuft, but there was basement membrane thickening and duplication along with this mesangial cell interposition. Also, how we see the basement membrane thickening is that the thickening is matching with the atrophic tubular basement membrane thickness. And as a protocol, so this was MPGN pattern also with crescents. There were out of 20 glomeruli, 11 glomeruli were showing crescents, diffuse cellular crescents were there. Congo red, this is under the polarized polarization, which is not showing any apple green or any reddish birefringence. So that was negative for amyloid. Then immunofluorescence was showing IgG positivity along the peripheral capillary loops, that is capillary lumina, and in the mesangium. That was coarse granular positivity. And why here it is not? Because this is a crescent and extracapillary stains do not take the stain. That's how we can differentiate it is a crescent on the immunofluorescence. And C3C was also strongly positive. So IgG, C3C were positive, and kappa was 2+ and lambda was totally negative. So the difference of 2+ we can take it as restriction. So this was IgG, C3C, kappa positive, and kappa was restricted. So the diagnosis was given as proliferative glomerulonephritis with monoclonal IgG kappa deposits, that is PGNMID kappa. And there was pattern of injury was MPGN pattern of glomerulonephritis with crescents, diffuse crescents. There were focal global glomerulosclerosis and mild IFTA along with some tubular injury and mild arteriosclerosis. And the chronicity score was given as 3/10. Chronicity score is given into 4 categories like glomerulosclerosis, then IFTA, that is tubular atrophy, and interstitial fibrosis and arteriosclerosis. So for each thing less than 25%, 20 up to 50%, then more than 50%, 1 each. And for that becomes 9. And then for arteriosclerosis, there it's 1 and 2. So when if it is the intimal fibrosis thickening is less than the thickness of the media, it is 1. And when it is 0, and when it is more than the thickness of the media, then it is given as score 1. So like that, the 10 scoring, out of which it is mild score 3, and ancillary studies was congruent stain is negative for amyloidosis. This is the pattern that is Sanjeev Sethi et al. They have given for the reporting of MGRS. There is a recent paper in CJASN which is showing this light microscopic pattern in PGNMID in which this diffuse crescentic pattern was seen in only 2% of their 46 cases. So there is one more entity is now recognized. It was given in KI reports that PGNMID LC, that is light chain variant only, in which we can see only C3C along with one of the restricted light chain, and definitely we have to do pronase digestion or paraffin immunofluorescence to see whether this IgG or any heavy chain is masked, and then we have to conclude that it is not masked and PGNMID LC is there. Thank you.
Thank you, ma'am. So I think we'll take the questions at the end. And so with this, I would like to now welcome and invite our next speaker, Dr. Suhas Monde.
Excuse me. This presentation is in 2 parts. Just a minute. So if you want the second part of the discussion about the case, about the treatment and the follow-up, I can continue. Otherwise, we can, due to limitation of time, we can go to the next speaker. It depends on the panelists what they like to.
I think you should continue, please.
That's fine.
I think we continue and finish it up quickly so that
Okay.
we can finish up the questions and then the panelists can give their points and take the questions.
Okay. So, yeah. So the diagnosis after the biopsy was a crescentic glomerulonephritis, PGNMID. More than 50% of the glomeruli had crescents. So this entity, although not very uncommon, it is a challenging diagnosis with dialysis requiring chemotherapy. And this patient who needed a bone marrow biopsy to rule out multiple myeloma after having gone through multiple challenges of non-ST elevation MI and catheter-related bloodstream infection, was completely reluctant for a bone marrow examination and not even willing to go for a oncology consultation. And I was faced with the challenge of managing her on myself. So how do we investigate such cases of PGNMID? We look at the serum monoclonal proteins by doing serum protein electrophoresis and quantify it with immunofixation, do free light chain assays to look at the clonality of the cells, whether it is the plasma cells, clonal plasma cells, or the B cells. We look at the bone marrow, aspirate and biopsy for immunohistochemistry with markers like CD138, which are plasma cell markers, CD20, which are B cell markers. Staining for kappa and lambda light chains should be performed to demonstrate that an identified clone exhibits the same light chain restricted as the monoclonal deposits in the kidney. Cytogenetics with FISH can help in risk categorization and choosing the chemotherapy. So in this case, because we did not have a bone marrow examination, we did a PET scan to rule out any bony lytic lesions and whether it is MGRS versus multiple myeloma. So the PET scan did not show any bony lytic lesions. Now here, without the bone marrow examination, we cannot say whether it is multiple myeloma, because the first criteria is to have more than 10% of plasma cells in bone marrow. with one of the CRAB, that is hypercalcemia, renal involvement, anemia, or the bone involvement. In any case, this was a case where we need to treat it, and how do we manage this patient is, first is look at what is the clone detected in bone marrow examination, whether it's a plasma cell. If it's a plasma cell clonality, then bortezomib based therapy, bortezomib with cyclophosphamide and dexamethasone. If it's a B cell clone, then it should be a rituximab based, either rituximab alone or with again the dexamethasone and cyclophosphamide. If there are no clones detected in the bone marrow, based on the serum or urine monoclonal protein detected, whether it's a non-IgM or a IgM. If it's a non-IgM, that is, we consider it as a plasma cell clonality, and bortezomib-based therapy is used. If it's a IgM detected in the as the monoclonal protein, then rituximab-based therapy. If there are no clones detected and there are no monoclonal proteins in the serum or urine, but it's only in the kidney that we have seen this restriction, then based on the non-IgM or the IgM deposits in the kidney, or based on the renal dysfunction, presence of renal dysfunction and the degree of proteinuria, we can decide treatment. If there is more than 1 gram proteinuria and renal dysfunction, it should be treated with immunosuppression, either with rituximab weekly doses, 4 doses for IgM deposits, or bortezomib for non-IgM deposits, or switch the therapy if one therapy fails. If there is no renal dysfunction and the proteinuria is less than 1 gram, we can continue to conservatively manage these patients with BP control, ASA, antiproteinuric measures for 3 months with monthly monitoring of SPEP and UPEP. And if no response or worsening, then start with the chemotherapy. Monitoring is with SPEP or SIFE with monthly monitoring of these with these tests, 24-hour urine collection for total protein, electrophoresis and immunofixation, free light chain assays, and serum creatinine. Once the 6 months of therapy is completed, after completing the active treatment, then these tests are done every 3 months. Some monoclonal proteins that are initially undetectable may become detectable later in the course of disease. So we keep monitoring them, do a surveillance 3 months. If the patient has now become an end-stage kidney disease, then need not be treated unless they have an extra-renal manifestation or they are candidates for kidney transplantation. In my case, she had M-band present. It was a IgG and kappa, which was matching with the deposits seen in the kidney. The free light chain ratio was 4.7 with the free kappa more than 100, and the beta-2 microglobulin was high. PET scan was negative. So she was a MGRS, and total 6 cycles of chemo, bortezomib based, because it was a non-IgM monoclonal protein, was given along with chemoprophylaxis for PCP and antiviral. In the follow-up, she continues to be dialysis dependent. She has not recovered because of the delay in treatment with an aggressive crescentic GN, despite of not having so much chronicity. Such PGNMID, if not treated in time, can lead to ESRD. The reason we have treated her is now she has agreed after completing 6 months of therapy for bone marrow examination, and bone marrow now doesn't show any plasma cells. So she has attained, or maybe she did not have any clones there. In PGNMID, around 40% you do not see any B cell or plasma cell clones. 40% you don't have monoclonal proteins as well. And this case, PGNMID treated adequately now can also be a candidate for renal transplant, because the bone marrow doesn't show. Once they have achieved complete remission, she can go for transplant, as transplant it can be a viable option for such patients who do not have any bone marrow things, or there are no multiple myeloma criteria. Thank you very much.
Thank you, sir. So, with this, we are now moving ahead with our next speaker. I would like to welcome and invite Dr. Suhas Monde, who's a consultant nephrologist at the Urukul Hospital, Pune. a DNB General Medicine from Pune Hospital, then a DNB Nephrology in Care Hospital from Hyderabad, a fellowship in solid organ transplantation from 3 universities, that is University of Canada, then the diploma of the Royal College of Physicians and Surgeons of Canada, and the affiliation to the American Society of Transplant. Fellowship in glomerulonephritis from University of Ottawa, Canada, fellowship in clinical nephrology from University of Western Ontario, London, and Canada, hemodialysis fellowship, London Nephrology Department. So has been associated with the International Society of Nephrology courses, a clinical nephropathology certificate course, and of course, an advanced clinical nephropathology certificate course in transplant and onconephrology. So over to you, sir, to discuss on glomerular disease registry initiative.
Thank you so much. After these all wonderful lectures, I'll be presenting something which has been more need of hour as of now. Sorry for my voice. My apologies. Respected panelists and all the colleagues who are joined from different parts of the world, I bring my greetings from Europol Hospital, Pune. For this presentation, I am not having any disclosures, which is regarding the finances or any conflict of interest, which is presented in this material. To start with disease registry, obviously it has to start with the very difficult definition. The definition starts like application of capturing, managing, providing access to the condition-specific information for the list of patients to support the organized care. But what it means? It means that we need to get a data first. As Dr. Girish was mentioning in his talk regarding the data collection, once we get the data in any sort, in various aspects about the patient's background, the previous histories, the comorbidities, the patient's treatment, the outcomes, everything, the complications which occur during the patient's treatment, everything. And this data, once we can get it, we have to understand what things we can make better to help the outcomes, so that we can treat the patients in a better way. First of all, that's what nothing but is a quality improvement. The second, which will be there, that the same data which we can use to understand the disease itself in a much detailed way regarding the etiology, the different mechanisms, the mechanisms which are not yet established. And this all we can use for the research purpose, which will give us the better outcomes, better treatment plans, better monitoring systems for the patient. The data can also give us a understanding whether the treatment which we gave whether it was efficient or not. So that if the data says that the outcomes of the patients who were treated with such and such way, the outcomes are not good, that means the treatment was not efficient. We have to find out the treatment in a better way so that we can help the patients in a better way. And we also need to understand that how in an easier and a better way that we can help the patients so that we can monitor the disease in a stages and outcomes so that the progression of CKD can be withheld. And this all is something which we have to do it in our scenario. So there are guidelines, material available from across the world, but that has to help us in our clinical scenario. I have been part of the Canadian GN registry when I was in Ottawa, but the scenario over there is not the same what we are facing here. In the last 1 year, I realized that whatever patients I am having here, the decisions are not that easy what we used to have it in Canada or Ottawa. Sometimes we are in a catch-22 situation, even for the smallest possible disease. And this needs, as I said, the data from India or like from our hometown so that we will be able to take the patients better care. We need to find out what better treatment is. Nowadays, if you see that, for example, the rituximab being used for most of the glomerular diseases, but here in India, when we are giving rituximab, we are facing more challenges like infections, UTIs, even the UTI being one of the major comorbidities for the patients who previously received rituximab, which I realized after coming and last 1 year of practice over here. So I understand that if we can get a data about the glomerular patients here, their establishments, their background, their treatment plans, then we'll be able to provide a guideline in a better way so that we'll be able to treat them in a much easier and much safer way. We also need to find out that when we are using the trials or the guidelines, we most of the time using the probably the same data which is being used in the Western, but that may not be the scenario which we always see. And to explain this, the outcomes of the Western population or Western data is such alluring that we need to happen to accept it as what it is. But it may not be the same throughout. We assume that whatever findings we are getting, that might be resembling the same, but it may not be the exact same. So suppose the Mona Lisa, if I'm assuming from the Western data, the Mona Lisa, what I might be seeing at my home place might not be the same. And that's something which I need to ask each and every one of us, that whether we need to have a better platform where we need to get data from our own country, our own place, and put it together to find our best possible outcomes and best possible patient care which we can offer to our patients. There is some data from the US. They have started their GN registry from 1980. But even though if you look at their major trials, lupus, then IgA, FSGS, the sample size is not that great. The sample size is something which we can definitely try and compare. But the effective data collection, the electronic medical record, the way they try to get the data from the patient, the social workers, from their infrastructure, pharmacy, labs, is something that will help to generate the more effective, productive data, which definitely gives more answers for the questions in my mind. There are some pros about the GN registry. One of them is that we'll be able to understand the course of Indian patients, the progression of our condition. The other day I was discussing with one of you saying that the FSGS, even though it says that tip lesion has to improve so fast, but one of my patients is not improving. Why? Whether the diagnosis needs to be revisited, whether I need to talk to my nephropathologist, whether I need to consider some other treatment, whether I need to give the realistic number to my patients to explain them that condition. It's not only the understanding of the condition, it's also the comorbidity burden. The infection, what we see, is not the same what the Western or the European data says. Infection in the form of tuberculosis. How often we see our patients getting the malignancy workup done? My patients don't get that regularly. And I'm worried about the missing of any malignancies when I treat with them for any immunosuppression. For vaccines, I've seen that even though patients been on treatment, they have not been vaccinated for long. I've seen that the need of our patients needing the anticoagulation is not the same as the Western. The number of the DVTs or the episodes of thrombotic events in Western population is exuberantly high as compared to what we see over here. So obviously there are some guidelines which we need to understand, but there are some guidelines which we need to rephrase so that we'll be able to take better care of our patients. There is a newer treatment data, but whether that data or that treatment is affordable to our patient is again a question, because here, even if we start considering the minimum possible immunosuppression for our patients, the first thing in mind of the patient is about finances. They are not covered by most of them by insurance. Most of them are paying by their own pocket. So we need to have an effective treatment, and that also with pocket friendly. Nowadays, the good part is that even the individual practitioners are using electronic medical data in the form of their own clinics, and OPDs are having softwares where the health clinics or doctors OPD, where they can keep a record of that, and which we can utilize or which we can combine together, all of us, so that we can be able to generate the good outcome out of it. In the cons, I'm not saying that the path will be easy. Obviously, as Dr. Girish also mentioned, that we need to have a ethical committee at our each setup, our each hospital to ascertain this. We need that data to be collected in a uniform way, where we can have the same things to be looked at, so that we can collect that data and generate some outcome out of it. Again, when we are collecting a data, we need to think about how that data is protected and how we will be able to store it. Even nowadays, earlier there was a challenge of having the data in which format to be collected. Nowadays, at least we can have online or cloud-based server where we will be having the data storage, and that will be now an easier way as compared with the previous times. The type of studies, obviously, here when we will be able to answer a question or a GN condition, suppose IgA nephropathy or FSGS, we need to decide that initially when we are all together, whether we'll be able to put something like a retrospective or an observational based study, or something where we'll be able to have like a prospective, where we'll be having a randomized group which will be able to guide us throughout our guidelines. We also need to understand that how we'll be able to generate the funding for it, because nothing will go without funding. It will not last longer. If we need to take it far, we need to decide that how we'll be able to generate the fundings so that we'll be able to continue these efforts. We are having good clinical skills. In India nowadays, there is like a medical tourism. People are coming from across the world. I'm at a place where we get patients from US, Canada, Europe, Middle East to be getting treated for their conditions. So definitely we are a center of excellence. But along with that, we are also having a huge data. The only thing is that we need to collect that data so that we will be able to analyze it. Once we'll be able to analyze it, we'll be able to have that eureka moment where we'll be able to answer many questions. The survey sheet is not too different. It's not that it needs a very minute data or very in-depth analysis, but it needs to be started at somewhere where we'll be able to get a background, patients' comorbidities, what was the biopsy, how it was treated, how was the outcome. And once we need to put it together, we'll be able to guide it in a better way. This is not too long. This is from CJAS in 2016, where someone was trying to understand that to get a GN registry, how difficult it is, where the pharma company, where the hospitals, universities needs to be together and continue doing hardships just to understand that how the effective and the better treatment can be offered to the patients. They also face the hurdles. It's not only we, it's not too old also. It's just 2016. There was a Spanish GN registry which was started in 2020. Canadian started in 2018. So it's not too far. We are still in a good way where we can start it together. I wanted to show a paper which was studied in pulmonary fibrosis in ANCA vasculitis, a series of 49 patients contributed by 26 nephrologists. So it's not something that I'm saying that it's difficult. It's just that even there is a attendance of 72 listeners today. So if even one of us can contribute one patient, we'll be having a very good data where we'll be able to understand it, analyze it, and we'll be able to get something good out of it. There are previously done trials in India. This is ICMR study where out of 98 trials which were done in nephrology from 2012, only 11 are there in the glomerular nephrology. So out of which 3 are lupus, 7 are nephrotic syndrome, most of which are pediatric nephrotic syndrome, and only 2 of them from membranous nephropathy. Previously, even the groups have come together and formed a source where the study and the data collection for the glomerular nephritis can be done. It's not the first one, but what we are seeing is just again the Mona Lisa in the parts where we need to see in a whole. There are many stalwarts in the nephrology who are coming together and asking for the GN registry, but we all need to come together, put our efforts together and find out. And obviously the Nephrocon is just one of them. So I'm all open for discussion, criticism, and thank you so much for having me here.
Thank you, Suhas. That was a great account. So if Seema allows us, can we start some questions?
Yes, sir.
Okay, so I'll start the ball rolling. My first question is to Dr. Vinant. We just heard a case of paraproteinemia. Dr. Krishna gave us a very great account. What is your take on extracorporeal removal of these paraproteins? How frequently you do in your practice, and how is your take on the outcomes? Like, I'm not talking about the treatment outcomes. I'm talking about the patient outcomes. So what's your comment on it?
Yeah, first of all, Dr. Girish, I was expecting that question from you. has to come, extracorporeal has to come from you. That's one thing. Second of all, I would like to congratulate organizers of Nephrocon. I think this has been quite a good 90 minutes that we've had here, in which we've had discussions from nephrologists and pathologists. Coming back to your questions about extracorporeal management in patients who have plasma cell dyscrasias, fortunately or unfortunately for the patients, we have good therapies, monoclonal antibodies available right now. And hence what has happened is that we cannot justify the use in the present day literature, considering the present day literature of using extracorporeal therapies for removal of either light chains or heavy chains in terms of a literature guided answer to this kind of a question. We have used a couple of we've done plasma exchanges a couple of years back when there was some data on use of plasma exchange, but unfortunately none of our patients actually did benefit from it. And then we've also used other filters like the Theralite filters. We've used heavy chain removing filters, but unfortunately there are two roadblocks here that we see. One roadblock is the fact that most of these filters are economically not viable for our patients. So it's very difficult to analyze long-term data with this kind of patients. And so we've lost most of our patients who have just given up these kind of therapies for us. But we are confident about the fact that now we have so many new arenas opening up in nephrology, onconephrology especially, with different monoclonal antibodies coming up, that I think extracorporeal has probably taken the back seat for the meantime.
I had a case. I had a case where a patient with light chain cast nephropathy for 2 months on dialysis, and we did a high cutoff dialysis for this patient, 2 sessions, and she. I cannot say that was the only thing that has contributed to the recovery, but the chemotherapy and this together, she is now maintaining at around 1.5 creatinine off dialysis. So there are some cases where we can see some dramatic response, but definitely depends on the chronicity and other factors. How much?
Yes, yeah, Dr. Krishna, I should congratulate you for that patient. That you've been able to use high cutoff dialysis and high cutoff dialyzers for the patient, but unfortunately, we haven't seen anything of this sort with just 2 sessions, and I would actually attribute it to existing treatment, the pre-existing treatment that this patient has undergone. And we've seen remarkable responses in our patients even up to 6 months, or maybe even after 9 months of complete remission, and patients coming back to us with an absolutely normal creatinine. And these are patients who presented to us with rapidly progressive renal failure. So that's the kind of dramatic response that you see when you have complete remission. Attributing it to extracorporeal is with just 2 sessions, I don't know.
Thank you so much, Dr. Vinant. Thank you so much. And my next question is to Dr. Anila. Madam, good evening.
Hello.
Hi. So as you could see the case, the kidney biopsy was delayed by almost 4 weeks because the patient was on antiplatelets, patient has a coronary event. So the diagnosis of crescentic GN came after 4 weeks of the insult. Okay. So do you see any possibility of having urinary biomarkers that would help us during that period where the biopsy is not possible? Do you see the liquid biopsy coming again in vogue, or we need to rely on some novel methods of doing biopsy like a transjugular biopsy, going when patient is on antiplatelets or with some coagulation? What is your take on it? Like how are we going to get benefited and prevent that 4 weeks of period from not taking a decision on the patient?
Yeah, that's something that's completely out of my field because I report only renal biopsies. I don't do any liquid-based or urinary biomarkers.
Right.
So I really wouldn't be able to answer your question on that.
Yeah, I can take that. I can take that.
Thank you.
Yeah, thank you so much, ma'am. So that's a very interesting question, actually. You see, what happens is that this is the kind of scenario that we see patients on dual antiplatelet agents, and they come to you, and and you don't know what exactly to do with these patients. Unfortunately, we've reviewed the literature, we do not have any significant biomarker that can replace a kidney biopsy.
Absolutely.
And now we have substantial data that if you are off your if you're off clopidogrel, you can do a biopsy even on aspirin, as long as you use an 18-gauge gun and you use an ultrasound guidance, provided the fact that you do it with the guidance. And you have newer methods now to do biopsies, like the coaxial gun. You also have you have specialized glues that you can form a tract with, and then you can, which is called the DBCA glue, which can actually just be applied to the point of insertion, and that creates a tunnel, and so the bleeding just stays just about in that point. So these are for high-risk patients. So the threshold to biopsy a patient who has a clinical diagnosis of RPGN, I think, should be very low, because the earlier you diagnose, the earlier you treat.
That's perfect. So whenever you are in doubt whether to do a biopsy or not, we biopsy.
Yes.
That should be the first commandment of today's talk, I think. So Dr. Anila, coming back to you, do you see any particular time frame which is very crucial to make a diagnosis in such cases, what Dr. Krishna Patil presented? What would be your ideal time to do a biopsy? Would you suggest something on that?
Yeah, see, the ideal time of the biopsy is something that we really, a pathologist cannot dictate, because invariably, if the biopsy is late, we know it's due to some of the reasons that you previously mentioned. But a crescentic GN, the earlier you biopsy, obviously, the better, because we hardly get serial biopsies to know at what time a cellular crescent becomes a fibrocellular or a fibrous crescent. So if you can pick it up at the cellular stage, yes, you can treat it. But once the crescent has progressed on to a fibrous crescent, it's an irreversible damage. So that is one. And if I may just add something to what Dr. Radhika has already described for me, she's done an excellent presentation there. One thing that this case really highlights is the importance of doing both kappa and lambda light chains on all biopsies. Okay, it's unfortunate that even now we are almost moving to 2024, but occasionally I get biopsies for review from other centers or some peripheral centers where they have not done kappa lambda.
Absolutely.
Kappa lambda, I don't know why, for some reason, is done selectively on like how we do Congo red, right? We don't do Congo red in every state. They do it on cases like kappa lambda by some specialists is still being done only when you're suspecting myeloma, or only when you see CAS, or when you see a myeloid. But you need to remember that kappa and lambda have to be done on every single case. So this, from the pathologist part, I would like this to be the take-home message for all the nephrologists here, so that you communicate with your pathologist and ensure that irrespective of the clinical presentation, irrespective of the light microscopic and the IF presentation, you do both the kappa and the lambda light chains, because a diagnosis of PGNMID can never be made otherwise.
That's well said.
That is one. And the second thing, by definition, PGNMID has to show IgG subtype restriction. Like it is by definition IgG3, or rarely it could be IgG1. I'm not aware of many centers in our country which do IgG subtyping. Probably Dr. Alok is here and he does it. But otherwise, by and large, we make a diagnosis on PGNMID by ruling out the other possibilities with light chain restriction. So that's another thing that probably in the future we would be doing subtyping more often and in more cases. But light chain definitely, without a doubt, should be done on every renal biopsy. Because PGNMID, the age range is from 5 years to 80 years. A child of 5 years, you may just see the light microscopy and call it as a post-infectious GN or an MPGN immune complex type. Had you not done kappa lambda, the whole diagnosis changes. So that's a take-home message from my side. Thank you.
Thank you so much, madam. Thank you. That was a great understanding. At this point, I would like to involve Dr. Urmila Anand, madam. Madam is there. I couldn't see.
Yeah, but has no voice. So I think Vinand can take care. I have a very bad throat.
Oh, no problem, madam. Please take care. You just please listen to what me and Vinand will discuss
just one
now.
comment I would like to make.
Yes,
on
ma'am.
the talk. See, the rule of thirds for membranous actually does not applicable nowadays. With
Okay.
Dr. Vivek Jha's randomized control trial as late as 2007 or 8, I mean as early as
Yes, yes.
2007 in
Yes.
Jason,
Yes.
showed only 10% of membranous actually progress to end stage if
Yes.
you treat them. The rule of thirds is only applicable to untreated membranous.
Yeah.
So that is something we ought to understand that. So I just wanted her to. And the second was FSGS, please. I think Dr. Anila will also agree, is not a disease anymore.
Yeah.
It is a podocytopathy, a pattern.
Absolutely.
And the
You can-
Columbia classification is no longer in vogue.
Yeah.
We
The
don't
Columbia
now it's like a
classification
primary
doesn't exist.
FSGS or a secondary FSGS or a genetic disease associated FSGS.
Yeah, because that Columbia classification is not there anymore. And I think Madam will be able to tell you, the more diffuse the podocytopathy, more chances of it being primary.
Primary, yes,
Yes.
definitely.
Thank you.
So
I
Vinay,
think, please go ahead. My clinical colleagues will take care, but I'm there.
yeah. So madam, just please listen to what we discuss and just correct us wherever we go wrong.
Actually, I'm listening to that, and
Yeah.
Dr. Anila is also there. So
Vinant, see, after all this talk, we have identified two knowledge gaps. That's all it's all about. So we identified first knowledge gap as we don't know when and how and for how long to remove the extracorporeal substances in a patient with paraproteinemia or plasma cell dyscrasia. One. Second thing, we have not yet identified a substance in the biopsy tissue in the histopathology or in the urine or in the serum that will tell us the activity of the disease. So do you think such kind of knowledge gaps will be bridged if we float in a glomerular registry across the country or at multiple centers in the country? And do we get some answers out of it? How do you, what are your tips to go about it? Like, I would like to hear.
Yeah, thank you, sir. That's a very interesting question. In fact, I was thinking of discussing about that. Maybe if you could give me some time. So the first thing is that we do have a couple of molecules which are moving around. They're creating some ripples about the disease. One obviously is the Pla2 receptor antibody, as we can detect them in the serum. That's one thing. And the second, which is very interesting, is the role of galactose deficient IgA, which has been seen now in patients with IgA nephropathy. In fact, we have a couple of studies which will be coming out from CMC Vellore, I think, because they're doing some work on this particular molecule. And I was told that one of these students and one of the PhD students has been involved in this work. So we'll be looking forward to some kind of data that comes from Indian subcontinent regarding the role of this particular molecule, which is galactose deficient IgA, as well as IgA and G immune complex formation. So these are two things that could be of interest when we are generating some amount of data. But all of this is actually just in infancy. So I totally go with what Dr. Monde has to say, Dr. Suhas Monde, that we have to start from somewhere. So the start has to be something which is very easy to do and should be very practical for everybody, so that a lot of people participate in the registry. Rather than complicating issues and making it tough, I think it's best that we make it very simple, so that he's very clearly told us that I think that's the way it should be done. And we're not too far away from generating our own glomerulonephritis or glomerular disease data. And I'm sure that this group is going to be a very helpful partner in allowing us to collate all the data from the rest of different parts of this country and get it into one form.
Absolutely. So I think we have actually overshot our time schedule. So if there are any questions from the house, they are welcome in just 5 minutes, or we can just take leave for the next first Friday of every month. Simaji, any questions in your chat box?
I think we have a few comments from MK.
Okay.
Actually, I am Muthu Kumar.
Hi, Dr. Muthu.
Hi. Actually, I'm knowing Krishna Patil, and we were. I can share my thoughts on this the way of conducting a registry. That's basically the crux of today's meeting, I suppose. And this is a good initiative, and it has there was a group which was formed in like an young nephrology association. Like it comes under ISN only, ISN Indian Society of Nephrology, young nephrology association. So that meeting happened in the year of 2017, and we conducted the meeting.
Nephrologists are always young, Muthu.
Yeah, that's fine, sir. So that's that they like minimize the age to 40. So we took part in registry. I was presenting the same like Suhas was presenting now, a small registry from Australia which has brought data on their own simple questions like aspirin, statins, many more. Like then what happened? Then it became something an electoral group which was associated with some political things. Then research could not come up. So then at that time I was in private. We know that the disadvantages of conducting research in private sectors, although Dr. Vinant and others are doing it perfectly. And then when I moved to a government sector, we proposed last year 5 proposals of making a registry that like Indian Glomerular Nephritis Consortium. That was the name which was given. And that was that I took the mentorship of a senior nephrologist, like senior in terms of experience. And I try to want to act as a bridge to bring in some people who are working in an education institutes and academic institutes, a lot of DNB institutes. So we could contact from Kashmir to Kanyakumari. We have around 25 centers. And because IGA are worked by Dr. Susina and CMC and Dr. Bakshi ma'am and AIMS and few others are working on it. And I wrote a proposal on podocytopathies, particularly on MCD, FSGS, common questions which we daily ask. We don't know many things on that, but we do it without much of evidence. And then MGRS, like which we spoke, because in last year ISN, the number of posters on MGRS was very high, and then the leading paper was on around 13 patients case series. So it's a good move, like wherever you need and support from others will be into it. And it's a good move actually. If you want to do a registry, then we can bring in some data with nephrotics, including genetics.
That's great.
And such kind of meetings will really be helpful. But it has to be like Dr. Vinant actually is superpower now, and he can help us in conducting a very good registry, because we need to find answers for our questions.
Yes.
Because there are so many things which like some beautifully respond to some therapy. May not be like an umbrella therapy for everybody. As usual, Dr. Anila ma'am, I used to disturb her a lot when I was there in Vellore. Nice meeting you, ma'am, and others. So it's a very good initiative. Please continue doing this. It's a continuous effort. Wherever you input from all the things which I have done already, if you want, I can like share it so that you have difficulties you can take over that and make a good registry. That is very much important, and it's a potential thing. Like the potential thing is the group actually. So when we started it, the people were initially interested. Then it's very difficult to collect data. Then giving data, getting and consent becomes a difficulty.
Yes.
So all those things, there's so much difficulties which will come. At least I expect a common question with a small peer group is also will also become meaningful in due course. The other thing is the quality of reporting. I think Anila ma'am and Radhika ma'am, all those senior guys, will train the younger people, and that's great. Because there are no new labs are coming up, new people are doing the nephropathology. Sometimes very difficult to get a right thing out of them, although they are doing a great job. So all the best for this group, and it should be an excellent like a group which will take something for futuristic. And we will have data from our own country, and particularly involving every other nephrologist who are interested in academics.
Thank you.
So not only it's not be an institute-based or academic center-based. Whoever want to collaborate, they should be invited to collaborate.
Absolutely. More the merrier.
Thank you, sir. It's more than encouragement. I was needed. So thank you so much. Hats off to your efforts. I discussed with even Dr. Rajapurkar sir. He was joined for this same seminar for today. Unfortunately, he left, but he also mentioned that it's the way it will be. You will be starting, you will be failing, and then again you will be coming with some all like group and like with the similar minded people who want to have some good registry and good data to be collected for the country. So thank you so much, and we'll keep in contact for sure.
So Seemaji, I need permissions from all the panelists, Dr. Vinant, Dr. Anila, and Dr. Urmila Anand madam, to conclude this interesting talk, interesting discussions. So
Thank you.
Thank you so
very
much.
much.
thank you so much. Thank you so much. Seemaji, all over to you.
Thank you very much.
Thank you. Thank you to all the esteemed panelists and to
Thank you so much.
Dr. Suhas and Dr. Purvi ma'am. So I think there are no more questions. In fact, we have some comments that, of course, it's a great session and great discussion indeed. So congratulations to the organizers. So with this, we are then closing the session for today. And we are looking forward to meeting you all again next month in the first week of Friday, the first Friday of the month.
Yeah. Thank you.
Thank you. Thank you, ma'am.
Thank you so much. Good
Good
night,
night,
everyone.
everyone. Thank you.
Thank you. Bye.
Thank you.